Good morning. Welcome to your first pandemic morning report. I don't know about you, but we've had multiple technical issues on our end, and this is now basically the third time I'm going to be doing this, so I'm very excited for all the new technology involved in our lives. um, I know with Morning Report, we need to keep up with education in a time of crisis. And I certainly thought about talking about coronavirus, but the we're seeing a lot of that, and things are evolving so much that I feel that the evidence that if I were to present it today would be different in 2 weeks from now. And maybe some of us need a little bit of a break. And it was hard to find that balance of what's completely off topic, what's too lighthearted. And so I kind of felt like, you know what, let's do a good skin topic. This might be a good place to start. So here we are with learning about the skin, and make sure you stay at home unless you want to be intubated by a dermatologist. Oh, technology issues. Hold up. Okay, our goal is that no one leaves the clinic with an undiagnosed melanoma. I want you to start feeling confident in what are we going to biopsy, what are we not going to biopsy. And I think that the default is let's biopsy that because I don't know what it is. But we can be a little bit better. And what we also want is we look at something and not blow it off and not say, oh, that's nothing. And we can get a little bit better at what we're looking at. So this is what we've all learned in medical school and of course in residency, but our ABCDEs. So A, asymmetry. One half is unlike the other half. B for border, an irregular, scalloped, or poorly defined border. C, color. It's varied from one area to another. D, diameter. Melanomas are usually greater than 6 millimeters. And E, evolving, so it's changing over time. So with this mnemonic, your ABCDEs, we really would never miss a melanoma, right? But how many times have you used this in clinic, or, anytime someone's like, hey, you're a doctor, come look at this, which seems to happen in my family more often than it should. Um, but you look at something and go, gosh, I don't really know. I mean, I'm using my ABCDEs, but you're going, is this cancer? And I don't know. So let's get a little bit better about that. And so when we see these pigmented lesions, what can we do to start understanding them a little bit better and feeling more confident outside of our ABCDEs? What we do know is that the number of biopsies has increased more than 55% over the past 10 years. And this is despite the number of skin cancers actually holding steady. So this kind of shows us that a lot of us probably don't really know what we're doing at all. But don't worry, we have dermoscopy, and it can help with that. So dermoscopy is used to evaluate pigmented lesions in order to distinguish malignant skin lesions. And it'll help you to determine what to biopsy and what not to biopsy. It does take some practice, so I'm very happy with you always grabbing my dermoscope and taking a look. But we do know that if someone looks at a skin lesion with dermatoscope, that you are less likely, it reduces your biopsies about 30%. So it does make you more confident in if the lesion is malignant or benign. This is a typical scope. I have one in my desk. So it permits visualization of subsurface patterns of the skin. This is one of the most common ones that's used by primary care. It runs about $265 on Amazon, but they can be as expensive as $1,200. But they reassure both you and the patient. I think of it in a lot of ways as you look at a lesion real fast and go, no, that looks benign. Think of it in the way that we touch the point of pain. If we just hear about someone's pain and say, sounds like nothing, as opposed to if we lift up their shirt, we feel and we actually aren't afraid to touch that point of pain. We do a full assessment of it and we say, it's nothing. The patient feels so much more reassured about that. I think that it's the same when it comes to skin lesions. They go, oh, okay. But I think in their mind, they're like, well, I better keep an eye on it. I'm not sure if they know. Whereas if you take out a scope, you take a look at it and you really reassure that patient, I think it leaves another level of trust for them and they feel much more reassured about that lesion and they've kind of moved on from it. Definitely reduces the number of biopsies on benign lesions, which we discussed a second ago. improves your referral process to dermatology. Dermatologists actually leave spots in their schedule, just like we leave spots in our schedule for acute appointments. They leave spots in their schedule for melanomas. So it allows me, when I have somebody that I've already looked at it under the scope, to be able to text a dermatologist or call them and say, hey, I looked at this under the scope. It has this and this and this feature. I'm concerned about melanoma. How quickly can you get them in? And they can usually get them in within the same week, if not maybe the next week, but usually same week, as opposed to like the 3-month waiting line of a new patient for just skin check of just a typical referral process. You can use this with or without oil. It really does need some liquid on it though. So even water in a pinch, but I really love just the jelly that we have in the room. So the jelly that we use for pap smears or rectal exams, whatever else we're using that jelly for, that's perfect. And I just grab a little bit, put it on the lesion, and it gives me that perfect medium. And we have to put this right on the skin. And those of you who have seen me do it and then have tried to emulate it, you know it goes right on the skin and your eye really goes right up to it. So it's a really up close and personal exam. So you obviously can't do it on every area of the body without being a little bit weird. All right, so now we're gonna get down to the checklist of how are we going to navigate an exam with a dermoscope. So when we're talking about suspicious lesions, we are talking about things that are asymmetrical, they have an atypical network, and they have blue-white structures. So this is outside of your ABCDE pathway. This is its own dermatoscope or dermoscope pathway. So number one, we're talking about asymmetry of color and structure in 1 or 2 perpendicular axes. Atypical network is a pigment network with irregular holes and thick lines, and blue-white structures, so any type of blue and or white color that is within the lesion. So we will first talk about asymmetry of color. Here's the typical colors that we would see under the dermatoscope. So black, brown, tan, gray, blue, purple, white, yellow, and red. And here's what these would look like in real life. So black, brown, tan, gray, blue, purple, white, yellow, red. Right now it's looking like on my screen, the white and yellow look pretty similar, but I think that if we can get over that and just really focus on the white central part of the white one and not the yellow on the outside, you can really see what that color differentiation looks like. Okay, so when we're looking at these colors and we're talking about symmetry of color, we're leaving everything else out of our picture right now. We are only talking about symmetry of color. Here's what this looks like with the top row being symmetrical, top row being symmetrical, bottom row being asymmetrical. And goes along with the top row is actually benign lesions and the bottom row is malignant lesions. So here we have our ink blot lentigo. So you kind of see that we're just focusing on color here, that the color is uniform throughout the lesion. And if we were to put a cross over it, we see that it stays pretty consistent throughout. Same here with this atypical nevus. This coloration has really stayed the same throughout. And this freckle here has this moth-eaten appearance to it, but the coloration of itself is symmetrical. Now, when we're talking about a melanoma, if we were to put a cross over this and look at it in 2 perpendicular axes, we can see that the coloration has not stayed the same throughout 2 different axes. Atypical lentigo, the coloration has varied throughout from dark to light. And here in this melanoma, we've got inconsistent coloration. So asymmetry of color. The next point that goes along with asymmetry is the structure. And that again goes in those 1 or 2 perpendicular axes. So top row being our symmetrical structures and bottom row being our asymmetrical structures. So if we were to put a crossover, and the cross can lie in any direction. So if we put a cross over a lesion, is it symmetrical in 2 perpendicular axes? You can see in the benign nevus how you could lie that cross going this direction over the SK, you could have the cross lying lengthwise along it. But when we look at the plantar nevus, this SK and congenital nevus, these are not symmetrical in two perpendicular axes. They're kind of all over the place. That does not mean that these are going to be malignant lesions. That just means that they do hit the criteria of being asymmetrical in structure. And these are also asymmetrical in color as well. Our next thing to talk about is your atypical network. When I think about the network, I'm actually thinking more about like the backbones of this lesion, the building blocks of it. What is it made of? What does it look like? What's the structure underneath? So atypical network, we're talking about those building blocks and backbone. So these are determined by either being typical or atypical. The left is the typical, the right is the atypical. So we're talking about typical. When we think about something that's benign, slow-growing benign lesions produce uniform network patterns. The lines are uniformly populated with benign pigment cells that grow at a slow rate. And the network is homogeneous in color and typically thins out around the periphery. So this is something that's taken a long time to build up. And because it took a long time, it all looks the same. It's built of the same material. The body did a good job of putting that structure together. Whereas when we look at something on the right, your atypical network, you can't really tell what it's made of. What are those building blocks there? So we look here, when we talk about melanomas, they consist of malignant melanocytes that vary in size and degree of pigmentation. Malignant cells move throughout the epidermis in all directions at varying rates and produce structures with bizarre patterns. Cells are numerous in some locations and sparse in others. So it doesn't really know what it's supposed to be. It's not following a blueprint as it builds itself. It's just like, oh yeah, I'm a cancer. I'm going to grow all the ways. I know that this is really off topic, but when I look at this, I can't help but think of it in the way of bone and bone structure. And when I think of an osteoporotic bone or osteopenia, and you're trying to figure out how you want to treat that, I have this kind of image in my mind with the typical network being good bone that takes time to build up. And we really are trying to build that. So that's where we can use Forteo, Temlos, Prolia, where we're using the body's own natural ability to build its bone structure. And it's going to take a little bit longer, but I promise it's going to be worth it in the end. Whereas here on the right side, I think of a patient on a bisphosphonate, is that atypical network. So we didn't care how that bone was built. We just wanted to fix our numbers. We just wanted those DEXA scan numbers to look awesome. So we put that person on the bisphosphonate and we grew bone. Do we care what kind of bone we grew? Probably not, which is why we fix our numbers, but we leave that person at risk for those atypical fractures. So a little off topic, but I like how we can kind of build it back together with this visualization. So these are some types of typical network, and it would just take too long, honestly, to pull together an example of every single one of these. But this is the kind of pattern that you would be looking for in something that's typical versus atypical. The most common one being diffuse reticular, meaning here on the top left, that something has a specific structure going all throughout it. Yeah, I mean, it's a little irregular, but it's kind of irregularly irregular, if you will. So you can kind of tell what it's made of and what it's supposed to be. Patchy reticular, same thing. It's consistent. Yeah, are there patches and are there some missed spaces? Yes, but that's not irregular, and those are very consistent areas. It's just in a patchy appearance. Here we have in the middle this reticular pattern with a central hypopigmentation. So it is still symmetrical in shape and color, as well as that network is symmetrical. There we have these peripheral reticular with central hyperpigmentation, a homogeneous presentation, and then we come down to the peripheral globules and starburst. All right, do these look a little scary? Are we not really sure what to do with that? Yes, but even that starburst pattern, it has a specific structure. It is a starburst. That's what it looks like. That's what it consists of. It's not a starburst in one section, and we don't know going the rest of the way. Yes, this one has some globules going around, but they're consistent and they're even and they're in a particular pattern going around. Same with the rest of this. Now, there's also the idea of this two component, which can happen. It still demonstrates some symmetry. I would probably freak out personally if I saw it, but in the derm world, apparently it's okay. But here's our examples of atypical network. So you can see up here at the top left, it was supposed to be reticular, I guess, but something went awry. And it definitely has lost that baseline structure and is just not really sure at this point what it's trying to be. Here's that negative space, which we would think of as opposed to the patchy reticular. So this is not something that is just patchy. This was something and it lost its structure. So it now has negative space as opposed to just being in a patchy position. Something that's reticular perhaps and has massive streaks coming off the side. Something that's reticular and has a big blotch located eccentrically. It's really about that asymmetry, not so much the fact that it has a blotch in it. Because if that blotch were located centrally, we would likely be okay with it because that would be a typical structure. Atypical dots and globules, so this one has dots and globules, but those are not in a regular pattern. They're different sizes, different components to those. Regression, a blue-white veil. Atypical vascular structures, particularly those that are kind of endpoint vessels. Crystalline structures, and ones that look like they've had a big, huge chunk taken out of it. So it's lost its structure completely. Our 3-point checklist, coming back to that. So anything that also has blue-white structures built into it. So here we have some examples. And again, the top row being benign lesions, the bottom row being malignant lesions. So here we have a congenital nevus located in the top left. And we can see that this is fairly symmetrical in shape and, in color and structure. Yeah, we've got some darker spots and lighter spots, but we can tell what that architecture is, and there's not a significant variation in the color in each axis. And then from a reticular standpoint, or from the structure standpoint, you can tell what this is. However, you can see these white spots here, here, and a blue structure here and heading into here. That is atypical, and that is a concerning feature. So that is the blue-white structures that we're referencing. Blue nevus, this one's going to be completely blue with some white in it. And it's same here with this blue nevus. Again, these are symmetrical in color and structure, likely symmetrical in both of these are symmetrical and have a typical network, but they are blue and do have that abnormal feature to them. So basal cell carcinoma, here we've got kind of a mess, right? So we've lost our symmetry here in color and structure. Where's our architecture here? So are we typical or atypical? We're atypical. We've got a bunch of like globule things. We've got some maybe reticular pattern that used to be down here. We've got a lot of vessels coming in. That is very consistent with basal cell carcinoma. And we see these big white structures coming in. Here's white structures. Here's these bluish spots. These are atypical structures that would be concerning features. So all of that is bad. Here we go on this melanoma. You see these white bluish structures here in the middle, as well as a loss of network, so atypical network and asymmetry in shape and, in structure and color. Here's a dysplastic nevus with those blue-white structures. All right, so coming back to our 3-point checklist, we're looking for asymmetry of color and structure, atypical network, and blue-white structures. So we're going to move on to some practice ones. All right, let's give you just a second to take a look at this and tell me how many points it gets, 1, 2, or 3 points. So first we're going to determine if this structure has any asymmetry to it in color and structure. And it's very symmetrical. So if we were to place a cross going across it, you can see that it is symmetrical in all areas and the color is symmetrical as well. It is a typical network because you can see what it's being made of. It has that reticular pattern to it. It has some variations, but that variation is consistent throughout without any consistent concerning features in the network. It does have a blue-white structure up here at the top of it, and that is giving it its one score. So it is a 1 out of 3, which we do not biopsy because we need to have 2 out of 3. This is actually a dermatofibroma. And I think several of you have brought me in to look at dermatofibromas and wondering if it's concerning lesions. They can actually look a lot like cancer, and they have this almost nodular basal cell appearance to them. But they have one unique finding, other than not looking scary under under a dermatoscope, which they don't. They look typically very regular and not concerning at all under a scope. But the one physical exam finding that can help you determine if something is a dermatofibroma is if you will squeeze the skin around it. So just go and pinch it, and if the dermatofibroma dimples in and sinks in, then you know it's a dermatofibroma. If it's a skin cancer or any other concerning lesion, it won't do that. So it'll kind of raise up with the skin as you pinch the surrounding tissues, but the dermatofibroma will actually sink in. Dermatofibroma, the best way to think of what that is I think of it as kind of a big ball of scar tissue, really. And who knows why they really start. I always think of them as maybe an ingrown hair or something that happened, and the body essentially walled it off with scar tissue. You can get rid of them with time over time with cryo, doing repeated cryo treatments, but it's usually not worth it to the patient unless it's like in a big area. You can only shrink it back with a couple cryo treatments, and eventually they might come back. But it's just essentially a ball of scar tissue. So when you squeeze that, it'll dimple in, and that's a good way to determine what that is. All right, so do your 3-point checklist on this one. So this one, when it comes to symmetry, I would say that is asymmetrical in color and structure. If we were to put a cross around it, we really couldn't find any area that mirrored itself. It has an atypical network. We're not really sure what this is made out of. Is it made out of globules? I don't know. Is it made out of reticular things? Ugh, it's hard to even tell what this is. And then we definitely see blue-white structures within it. So we kind of have this big blue-white structure here. I would call this a blue structure right here, possibly even here, and the white structures within this. So this one gets us a 3 out of 3 score, which is absolutely something we should biopsy. All right, next one. All right, so if we were doing our checklist here, this one is asymmetrical in structure, but fairly symmetrical in color, but it does hit the point for asymmetry. It has a typical network. So yeah, I understand that the color variation is different within it, but you can tell what it's made of. You can tell what those building blocks are trying to be. It's all trying to be one type of skin cell and one type of appearance. And does it have any blue-white structures? No, I would not say that this one does. Now, I could see how someone would be concerned about this area here and around here, but I do not feel that those are blue-white structures. This is actually, so this is 1 out of 3, which does not need to be biopsied. This is just a freckle. This is what a freckle or a little birthmark looks like underneath a scope. It'll show uniform pigmentation. You know, this is a little bit patchy, but it's fairly uniform. But it has this classic moth-eaten edge. So kind of like it's just been nibbled at like a leaf. So really when I see this and around here, that to me doesn't look like blue-white structures. It looks more like the moth-eaten edge associated with the freckle. Next one. All right, when it comes to looking at asymmetry, we have asymmetry of color and structure here. You can't really place a cross along it and get mirror images. We have an atypical network. It's really hard to tell what this is, and if it's anything, it's more vascular than anything else, which is atypical in and of itself, because a usual mole doesn't have a bunch of vessels heading into it. And blue-white structures, we certainly have plenty of those. So we have these white streaks going throughout, and we've got these kind of big white dots happening as well. This is basal cell cancer. It's a 3 out of 3, and it's definitely something that I need biopsy. So let's dive in just real quickly into basal cell carcinoma and say what a few things are unique to it. It likes to have some flecks of gray color, and it typically is this bluish pink appearance. So unlike this, which doesn't, I mean, you see some pinkish in there, this is just like an overriding bluish pink appearance. Asymmetrical arborizing vessels and focal ulceration. So it loves to have those vessels around it that kind of dive into the lesion. There can be some slight scaling appearance to it and some white areas of regression, which you definitely see here in this. Crystalline structures are seen. Those are those shiny white lines within it. Nodular basal carcinomas lose that blue hue and instead have a white rim around a central ulceration. And milia may be present. Milia being those kind of, for lack of a better word, zits within the lesion itself. And really those are just filled with kind of junk. You can pop them nicely, but milia are also those little white dots that older adults will get kind of around their eyes and on their back. Again, it's pretty easy to just break the skin with a needle and gently extract the milia out. And they heal up well. But basal cell carcinomas like to have milia in them. All right, 3-point checklist on this one. All right, so this one we've got some asymmetry of color and structure, but we have a very typical network. So although it has this patchy appearance to it, that is kind of part of its charm, if you will. So that's just who he is. He's a patchy guy. You can tell, though, even though he's patchy, what he's supposed to be. He's supposed to be this globular, patchy mess. And it doesn't look like he's lost his structure from one area of the lesion to the other area. He's just patchy all throughout. So that is a typical network and has not had a loss of that network. And then I would not say that those are blue-white structures going throughout the lesion. Those are more consistent with just that patchy appearance and having not really negative space because it hasn't lost that, but just nothing is filled in. So that's not consistent with those blue-white structures that we're talking about in our other lesions. So this is a 1 out of 3, which we would not biopsy. All right, so to summarize, we are looking for asymmetry of color and structure in 1 or 2 perpendicular axes, atypical network, so that pigment network with irregular holes and thick lines, and any type of blue and or white color. If you have any 2 of those, you should biopsy. Just one of those is not necessarily something that should be biopsied because, as you saw, even freckles or blue nevus, things that are completely benign, do not need biopsy just because they have that one concerning feature. So I hope that this helps you to clarify what you should biopsy and what you shouldn't biopsy. And I really hope that you start to feel confident when it comes to looking at these skin lesions outside of your ABCDE pathway. Thank you so much for all you do. I know that these are crazy times and we're all adapting. Um, I love you all very much, and I pray that you guys stay safe and that we can keep each other's spirits up and be there for each other. And thank you so much for all you do. Have a great day.